Okay, now you just let me know.
Okay, I see it now, so I'm going to create it.
Perfect.
All right. Hello and welcome to our program.
updates on the evidence-based management of osteoarthritis and osteoarthritis pain, recent guidelines, and emergent therapies. I'm Jean Liew. I am Assistant Professor of Medicine at Boston University School of Medicine in Boston, Massachusetts, and I'm joined today here by my colleagues who will introduce themselves.
Hi, my name is Mohammad Ursani. I'm a private practice rheumatologist working in a multi-specialty group in the Houston area, as well as a adjunct faculty to the University of Houston School of Medicine.
Hello, I'm Francis Berenbaum. I'm a professor of rheumatology at Saint-Antoine Hospital in Paris, in France, and very happy to be here and discuss with you about OA management.
So our faculty disclosures are displayed on the screen, and our program today is the first in a series of 2 live streams about the management of OA pain. If you haven't already, please participate in the pretest that's linked above and in our tweet as well. After the activity, please participate in the post-test polls below the stream or follow the claim credit link to complete the post-test and evaluation and claim your certificate. Also, be sure to check out our OA tutorial posting early next week on our Twitter account as well. So over the course of today's discussion, we'll be addressing the following learning objectives. Describe the disease burden of OA, including the unmet need for effective pain management. Apply current guideline recommendations to the management of OA and OA pain. And review clinical trial outcomes and current statuses of emergent therapies for OA and OA pain. So first, let's cover an overview of osteoarthritis and osteoarthritis pain. So OA is the most common form of arthritis, and it affects over 32 million US adults. We think of it as a disorder of the whole joint and not just of the cartilage. The pathophysiology is characterized by cartilage destruction as well as bone remodeling and synovial membrane inflammation. The prevalence of OA is rising with the rising aging population and increasing rates of obesity. OA is the leading cause of pain worldwide, and it's the 11th leading cause of disability. There's a high cardiovascular disease burden in OA owing in part to shared comorbidities and risk factors, but currently therapies target symptom control and none are disease modifying. This slide on the prevalence of OA is based on the 2017 Global Burdens of Disease data on hip and knee OA. The prevalence in this study was estimated to be about 303 million globally, and for the US, the age standardized incidence rate was about 317 per 100,000. So again, OA represents total joint failure, not just wear and tear, which was the old understanding. Muscle weakness can lead to changes in the tendons and ligaments and in their ability to function. The synovial lining can become inflamed and release cytokines and other factors that promote further inflammation as well as collagen breakdown. You can see on one side cartilage destruction as well as degeneration of the meniscus, which is common in OA knees. And then you also see new bone formation in the form of osteophytes. So this slide shows the burden of pain in OA. In an older NHANES study, among 319 participants with radiographic OA, nearly half reported knee pain. This slide shows a cross-sectional online survey performed in several countries, and among 1,500 respondents, 84% were reporting pain and tenderness that impacted their daily activity. And you see that they also commonly reported stiffness and gait disturbance as well that impacts their daily activity. So the final slide in this section shows the pathophysiology of OA pain. So this figure shows nociceptors in the joint that travel through the dorsal root ganglion, the DRG, in the spinal cord and then onto the brain. With injury, pain is protective, but with inflammation, nociceptors can become sensitized, leading to chronic pain. Alterations in nociceptive signaling leading to heightened pain sensitivity contribute to the development of pain in knee OA. Pain sensitization refers to an increased responsiveness of nociceptors to normal input. So now I'd like to get some thoughts from my colleagues. All right, so we have everyone back. Let's talk about the overarching goals of care for our patients with OA. We saw that symptom burden slide and how 84% were reporting pain and tenderness that impacted their daily activities. What are goals of care that you typically address for your patients?
So I can go first. The main question that we discussed to start the discussion is really their quality of life and what they expect for their daily activities to be like. So in order for us to get a better idea of what their goals are, then we can help cater therapy and of course look at multiple different angles to help manage the osteoarthritis, whether that's change in physical behavior, management with medications, education about the condition itself. And so putting things together will help, I think, over kind of an overarching benefit to the patient.
Yes, I totally agree with that. I think the main objective is the quality of life of the patient. This is very, very important. And so that need to interview the patient in order to really know what are his or her expectations. The second objective is to increase the physical activity, because we know that due to the pain and the increased intensity in pain in these patients, they adopt a sedentary lifestyle, which has a big impact in terms of morbidity and even in mortality. So I think it's quality of life, but also to keep in mind that physical activity is very, very important.
Okay, and many patients ask, especially at the initial visit, what can they do to prevent progression? Is this going to get worse? So what is the outcome for them?
Yeah,
what would you say to that?
Yeah, that's quite all patients are asking that, and fortunately, we know that we cannot really achieve this goal of delaying the process. So the message could be negative, and that's what we do not want to deliver. But we do know that this is very, very challenging. So we just I say that our objective will be to decrease your level of pain in order to increase your quality of life. And at the end, that's what you are looking for.
I think it's also important to highlight that unlike some of the other types of inflammatory arthritis, such as rheumatoid arthritis, where we have disease-modifying agents to help treat the actual cause and prevent the progression of it, there's currently the lack of a disease-modifying agent for osteoarthritis.
These are all really good points. And then I think we also addressed like this, how we address these concerns would vary across different patients and what concerns they bring to the table upon the first meeting. I think this segues into our next session. So Dr. Ursani, could you take us through some considerations for patient care and introduce us to our case patient?
Sure, absolutely. So in this section, we'll approach the management of osteoarthritis and osteoarthritis pain. We'll start with the goals of care in osteoarthritis. So as we discussed a few minutes ago, there's multiple different goals. You want to improve the mobility and function. You want to delay further progression. You want to decrease joint pain and stiffness. And ultimately, all these things will increase or hopefully increase the quality of life of the patient. In terms of managing osteoarthritis, it's you have to look at it from multiple different angles. It's not only from an educational standpoint in terms of educating the patient on their condition and what's actually happening to the joint on a day-to-day basis. You have to instill behavioral changes psychosocial changes, encourage physical activity, and then also of course, we use medications, whether that's topical, oral, or intra-articular methods or means. So our first case study is Miss Anna. She's a 57-year-old woman. She's an owner and a manager of a small local restaurant, which requires her to work long hours on her feet. Her past medical history consists of hypertension, type 2 diabetes. She's overweight with a BMI of 32. She has a 6-year history of radiographically confirmed osteoarthritis of both knees. Currently, she's attempted to do physical therapy, take acetaminophen, take duloxetine, but she really has inadequate pain relief. She's intolerant to oral NSAIDs, nonsteroidal anti-inflammatories, and she's unwilling to take opioids due to the family history of addiction. So I'd like to invite my colleagues back to discuss Anna's case and treatment. And her current symptoms include stiffness and pain, about 15 to 20 minutes upon wakening in the morning. She has not missed any days from work. She admits that the pain is a distraction, makes her reluctant to leave her desk for her more physical duties. On physical exam, there's no deformities and no visible signs of inflammation. And at this point, I'd like to invite my colleagues back to discuss Miss Anna's case.
All right, so although Anna doesn't explicitly report being dissatisfied with her current treatment, she's having persistent symptoms, and their impact on her daily activity suggests that there's need for improvement. So what additional information would you require before making any type of recommendation here?
Yes, so I think that what we need to know is when during the day the problem is the most important for her. So is it at the end of the day? Is it in the weekend when she wants to do some activity, physical activity, sports, or is it for managing the children, or when is the main problem for her? And also, I don't remember in this case if she mentioned whether she has pain at night or not. But we also need to know whether she comes because she's in a flare or whether this is a chronic stage.
And another point to ask her is how her symptoms have been progressing over time. So compared to 6 months ago or a year ago, does she find herself being able to do less activity or being able to carry out her daily activities with less efficiency as she was prior to, a year or so?
How would your management change if she had, I guess, more pain at night or pain at rest versus if she were just saying, I just have intermittent pain. I just have pain with certain activities like heavy exercise or climbing stairs. Like, how would your management change with different patterns of pain?
Mm-hmm. So usually when there is pain at night, it is usual that this means that there is a flare, and even more if at the physical exam there is an effusion. What we have not said that we are speaking mainly on the knee, okay, so on a big joint, and it's important because when there is this kind of flare, what I do propose usually is to perform an intra-articular injection of corticosteroids because it's a local effect, and we will speak later on comorbidities, and so it's maybe on a benefit-risk ratio. It's maybe more better to try first this kind of treatment, but it's not always efficient for a long time. It's sometimes just for a couple of days or even sometimes weeks, but not more.
And they would have to come into clinic to get the injection. So What would you recommend for pain control that the patient could do at home that wouldn't require necessarily a clinic visit?
One of the things that could be encouraged is a non-opioid pain medication such as tramadol. So she has not attempted to use that, and that has less of an addictive property. The second thing is she has attempted physical therapy. It hasn't specified specifically whether it was aquatic or not. Generally, when people are in aquatic exercise or aquatic physical therapy or even simply swimming, it's a lot easier on the joints, and it helps condition the muscles or focus on muscle conditioning.
Right, and I think some of her physical activity has been addressed, but not totally. So there's more to explore with her in this case. So thank you both, Dr. Ursani. Could you take us through some of the current guidelines, please?
Sure. So in 2019, the American College of Rheumatology and Arthritis Foundation, they published guidelines which consisted of both recommendations for and against non-pharmacologic and pharmacologic therapies in osteoarthritis. So on this slide, on the left-hand side column, there's recommendations for the hand. The middle column is recommendations of the knee, and the right column is the hip. So there's an overwhelming, strongly recommendation for low impact exercise, which includes walking, muscle strengthening, aquatic exercises without any hierarchy of one over the other. And generally, exercise is more beneficial if it's supervised. There's a recommendation for self-efficacy and self-management programs. For the knee and hip specifically, there's a benefit to, or a recommendation to weight loss, Tai Chi, and cane. And the weight loss was actually based on a study that was done in 2018, which showed that about 10% or greater weight loss or weight reduction had a significant improvement in WOMAC scores and pain indexes, and even a 6-minute walk distance exam that was done. For the hand, there's a strong recommendation for carpal metacarpal orthosis and a tibiofemoral knee brace for the knee. And there's a conditional recommendation for heat, therapeutic cooling, CBT, acupuncture for all three, hand, knee, and hip, kinesiotaping for the hand and knee, balance training for the knee and hip, other hand orthosis, which doesn't include the first CMC, and patellofemoral knee brace has conditional recommendations, paraffin wax for the hands, yoga, and radiofrequency ablation for the knee. Non-pharmacologic therapies that the ACR had recommended against includes a TENS unit for all three, hands, knee, and hip, ionotrophoresis for the hand, which is conditionally against manual therapy and exercise for the knee and the hip, conditionally against massage therapy, modified shoes, and weighted insoles for both the knee and the hip, and also pulse vibration therapy specifically for the hip. In terms of pharmacologic therapies, there's a strong recommendation overall for oral non-steroidal anti-inflammatory drugs for the hands, knees, and hips. There's a conditional recommendation for a topical steroid or topical non-steroidal for the hand, and a strong recommendation for the knee. There's a conditional recommendation for intra-articular steroids for the hands, and a strong recommendation for the knee and for the hip. And then conditional recommendation for all three with acetaminophen, tramadol, duloxetine. Interestingly enough, they have a conditioning recommendation for chondroitin for the hand and topical capsaicin for the knee. For pharmacologic therapies, the ACR recommends against includes bisphosphonates, which is usually used for osteoporosis, glucosamine, hydroxychloroquine, methotrexate, tumor necrosis factor inhibitors, anti-interleukin-1 receptors, which are generally used for more inflammatory arthritis. And there's a strong recommendation against using PRP for the knee and the hip, as well as stem cell injections. And there's a conditional recommendation against chondroitin for the hand, and a strong recommendation against chondroitin for the knee and the hip. There's a conditional recommendation against intra-articular hyaluronic acid for the hand and the knee, and a strongly against the use of it in the hip. There's a conditional recommendation against the knee and the hip with intra-articular botulinum toxin, as well as prolotherapy, and a conditional recommendation against using topical capsaicin for the hand, and overarching conditionally against the use of colchicine, non-tramadol opioids, fish oil, and vitamin D. So I'd like to invite my colleagues back to discuss these guidelines.
So thank you, Dr. Ursani. Let's move on to discussing a bit more about considerations for treatment selection. We've reviewed the range of available options, or rather the recommended and recommended against options by the ACR. So returning to our case patient, do you think that Anna would benefit from a change in her pharmacotherapy? And if so, what type of therapy would you consider for her specifically?
So what is very, very important, and I will come back on that later on, is to look at the history in terms of comorbidities, because the first choice now by many recommendations is to use NSAIDs as the first choice. This is due to the fact that we used to consider paracetamol, acetaminophen as the first choice in the recommendations, but we now know that the efficacy of paracetamol is so weak in OA that now it's not considered as the first choice anymore for that reason. But it's clear that the safety is better with paracetamol than with NSAIDs. So, in order to follow the recommendation, we have to be sure that there is no contraindication for using NSAIDs. And the main two contraindications are an history of ulcer bleeding and a history of myocardial infarction. Then there's some other comorbidities to consider, like hypertension, arteritis, and it's not true, or a ulcer, gastric ulcer without bleeding, but it's a relative contraindication. So this is very important to consider. The first point to consider is really the comorbidities for this choice.
Excellent thoughts there.
So in Miss Anna's case, she states that she was intolerant to oral NSAIDs, but she hasn't explored the topical NSAID, which is a strong recommendation from the ACR standpoint. So I think that would be a good option. Earlier we had mentioned intra-articular steroids for the knees, and then also the use of tramadol as well.
And the topical NSAID's a good choice in the US now that it's over the counter and not just relegated to prescription. Although I think cost remains a concern for some still.
Absolutely.
We talked a bit about exercise. What about guided, like supervised exercise programs, physical therapy? How do you address this with patients, and how do you make this recommendation, and how do you make the specific referral?
Quite all my patients will follow this physical supervised physical activity, at least as a prescription. Then we know that several patients will not follow the prescription. That's maybe the biggest concern. The biggest problem is how to be sure that the patient has been convinced but by what you have said during your consultation, in order to follow this prescription of supervised physical activity. But we do know that this is really in the core of the treatment. So the big problem is the fact that you have been convincing enough during the consultation.
Absolutely. I think if you can give the patient a specific recommendation for weight loss, and that can be kind of jumpstart with physical therapy programs. If you tell them, there's been significant improvement in pain scores and delayed progression of osteoarthritis, if you lose greater than 10% of your body weight, I think that gives patients a solid goal or a solid number to kind of chase after. And generally, when people are more goal oriented for a specific thing, it tends to be more successful as opposed to just keeping things out in the open or more of a theoretical, esoteric standpoint.
And we do have trial data regarding weight loss and exercise as well. So we can rely on those findings to discuss in detail with our patients. Okay, so Dr. Berenbaum, could you give us some more guidance on considerations for treatment selection?
Yes. So, of course, this is a very, very important question about the selection. So indeed, once the diagnosis of OA has been made, it's time to choose the treatment. And we must try to apply what we call the personalized medicine as much as possible. And this should be based on the phenotyping of the patient. And today, the phenotyping is based either on risk factors or could be also on imaging features. As you can see on this slide, for the risk factors, we distinguish between the post-trauma OA, the metabolic OA, the one which is linked to obesity, and the age-related OA. These are the main three phenotypes based on risk factors. And as far as imaging phenotyping is concerned, we distinguished OA that is predominantly subchondral bone when you have bone marrow lesions on MRI, synovitis driven with inflammation of the synovial membrane that give the inflammatory phenotype, and the cartilage phenotype with essentially the destruction of the cartilage. So what are the consequences for that, for the choice of the therapy? In fact, the phenotyping by risk factor is used today to implement the personalized non-pharmacological measures, the ones we have just discussed before, the weight loss for the metabolic phenotype, the prevention of trauma for the post-trauma way in order to decrease the risk for another trauma, the prevention of the falls for the age-related OA. So next slide. And on the other hand, the choice of drugs will essentially be based on the existence of comorbidities because almost all the drugs used to relieve OA pain have potential adverse events that can be serious. There are therefore contraindications to the use of these medications that must be taken into account when prescribing them. It turns out that diseases with OA very often have comorbidities. You see on this slide the different pathologies that are encountered in this patient. The first of which is hypertension. It's something like around 40 to 50% of your patients with OA that have hypertension. This poses a real problem, especially when prescribing NSAIDs, which are, as we have just said before, now the indication as a first-line therapy in the most recommendations. We can also mention the problem of age when prescribing opioids, whether they are weak or strong, with the risk of falls and confusions, in addition to the problem of constipation, which is quite a concern in old people. It therefore becomes very complicated to choose an analgesic drug treatment for OA patients. There is a theory the recommendation, and then the practice, which is sometimes much more challenging. And this explains why the local treatments, such as the topical NSAIDs or the corticosteroids, intra-articular injections, are often preferred during the flares. So for the next slide, the question is finally how to select the patients who justify an arthroplasty. Generally, the indication is given when the pain can no longer be controlled, when the quality of life is too impaired because of the pain or because of the difficulty to walk or any other activity the patient loves to do. And as a general rule, the surgeon decides to operate if, in addition, on that problem, clinical problem, he sees on an X-ray that the joint has deteriorated over the previous years. However, there is still a problem. It's that in 20% of the patients operated on for the knee OA and who have had a total joint prosthesis will continue to have chronic pain even though the operation went perfectly well. And unfortunately today, we are unable to determine before the operation who is at risk of developing this form of chronic knee pain, which is very difficult to control. And this is really a problem that is still not solved. So now I would like to hear from my colleagues on their thoughts about the considerations for the treatment selection.
Right. Let's talk about the considerations that come into play when you're thinking about surgery for a patient with OA in your clinical practice, and what comes up when you're bringing it up for the first time.
I think it goes back to discussing the patient's goals. I mean, are they able to meet their daily activity goals? Are they able to function independently as much as they wish they would like to? Have they tried and failed all other non-surgical, non-interventional modalities before jumping to the surgery? As an intervention.
Yes, and of course, what we are looking first is which phenotype do we have. We will also choose, as I have said on my slide, we will choose the treatment for the non-pharmacological, for the pharmacological approach according to the phenotype, whether it's an OA in an obese patient, or on a sport patient, but with a history of trauma. Or this will be taken into account at first.
Okay, and does our patient Anna meet the criteria for surgical referral based on the information that we have so far?
I don't think she does at this point. I mean, I think that there's still other non-surgical interventions we can take to hopefully prevent her from leading to a knee replacement or a surgical intervention. As we didn't specifically discuss, her BMI is higher than it needs to be to discuss weight loss. We didn't discuss intra-articular steroids. We didn't discuss non-opioid pain medication. We didn't discuss topical non-steroidal anti-inflammatory drugs with her as well. So I think there's still multiple different approaches that we can take in order to help her find some relief before sending her for a surgical intervention.
Yes, and the additional problem is that I think she's 57. So she's less than 60-year-old. Of course, we can operate with a total joint replacement in patients less than 60, but it's quite usual to try to delay till after 60-year-old, because even if it's a very good solution, the total joint replacement, but the revision is frequent after 20 years. So now with the life expectancy that is much over 80-year-old, we would like to have something else that could delay the total joint prosthesis. But it's clear that this is an unmet need.
Yes, and say Anna had in like the next 2 years or so tried other approaches and they were inadequate for pain relief and weren't able to meet her goals of care. And then say you had referred her to orthopedic surgery and they determined that she, for whatever reason at that point, was not a candidate for total knee replacement. In such patients, what other options would there be if they've tried everything that we've discussed already? They are unable to get joint replacement. What changes can we expect to see in the therapeutic landscape for OA in the near future? What other options might we have to offer them?
Yeah, so do you want me to speak now on the emerging therapies, or are you speaking on orthopedy, on the future for joint replacement, or
I
is
think
that
we could go into our next session for
okay?
emergent
We can
therapy
go
in
now to
OA.
the next section. Okay, so so yes, what about the emerging therapies? So next slide. So what we have seen just before is that the main reason for total joint replacement is the exacerbation of pain, despite the use of the analgesics we do have today that are currently available on the market. And what we know that even if we are able to act on pain, it has no structural consequences. But we know that even by acting on pain only, this could delay a total joint replacement, because this is the main reason why the patient go and see the surgeon is because of the pain. So if we decrease the level of pain, even if there is no intrinsic uh, uh, um, um, a structural effect, this may have an important impact on that. And there are several avenues of research in this field. I will just propose to detail two molecules in particular because they are the most advanced in terms of clinical development. These are the anti-NGF and the transcapsaicin. So, experimentally speaking, there is growing understanding now of the circuits of the nociceptive pain. Jean just showed in one of the first slides what is the circuits, and this is a little bit more detailed. For more than 20 years, numerous studies have shown that the major role of a soluble mediator, which is the NGF, whose concentration increases in the environment of the sensory nerves present in the joint in case of a tissue damage or inflammation. The binding of NGF, the nerve growth factor, so on its receptor track A, results in decreased activation thresholds of nociceptors and so a heightened perception of pain. As a result of these properties, there are several pharmaceutical companies which have developed antibodies raised against NGF, or even pharmacologic molecules that have anti-NGF properties, and these have as an objective the treatment of pain in osteoarthritis. So we're talking here about a phase 3 parallel group placebo-controlled study of subcutaneous tanezumab in difficult to treat patients with knee or hip OA defined by an inadequate response or intolerance to paracetamol, NSAIDs, and opioids or tramadol. And these were the inclusion criteria with a knee or hip OA. Any calgranulons was able to be included from KL2 to KL4. Calgranulons is a score on a radiograph that can score the level of severity of OA. So it was a 24-week double-blind treatment period plus a 24-week safety follow-up period. No, it's the previous one, please. No. But sorry, it's the next one. Yeah. Yes, thank you. So the goal was to look at two different dosage. One is 2.5, the other is 5 milligram every 8 weeks by a subcutaneous way. And the patients were equally randomized to the three arms. The co-primary endpoints were taken at 24 weeks, including WOMAC pain, WOMAC function, patient global assessment. And thereafter, the study continued in order to have a safety follow-up period of 24 weeks. And the baseline characteristics of this population were pretty much what you expect for such an OA population. If I remember, the BMI was around 30, the age was around 60-year-old, so the very usual population with a knee or hip OA, nothing very remarkable. So you see here the mean change from baseline at week 24 for placebo, 2.5 and 5 milligram. For WOMAC pain, it's the mean of 5 questions, each scored on 11-point NRS. The WOMAC function is 17 questions, and the patient global assessment PGA for such OA population was rated on a 5-point Likert scale. For tanezumab 5 milligram at week 24, there was a significant improvement from baseline in WOMAC pain, WOMAC physical function, patient global assessment, and for the 2.5 milligram, there was significant improvement in WOMAC pain and WOMAC physical function. And so on the next slide, you see the analgesic effect, which is early appearing in the very first weeks. Just to remember you that it's an injection every 8 weeks by subcutaneous way, and even in the very first weeks, the effect is there, and it persists throughout the weeks until the end of the study at week 24. So what is maybe more clinically relevant is to look at what is called the WOMAC improvement. So the WOMAC response, you see the over or equal to 30% improvement in WOMAC, over or equal to 50%, over or equal to 70% in terms of reduction in the WOMAC pain score from baseline, and also the last over or equal to 90% reduction. And you see here the pooled clinical results of 3 randomized controlled trials, all compared tanezumab with placebo. And here are the results at week 16. And what you see here is in gray the placebo, the light blue is the tanezumab 2.5, and the dark blue is the 5 milligram. And what is very important to note is to see that more than 2/3 of the patients on tanezumab have at least 30% improvement in pain, which is statistically more than those treated with placebo. And this difference is confirmed whether it is at the 50, 70, or 90% improvement level. And what is known is that even at 30% improvement, this is clinically relevant. So, as you know, or maybe you know, in the early clinical trials with intravenous tanezumab, there was cases of what we call RPOA, rapidly progressive osteoarthritis. And due to that, the FDA placed a partial clinical hold on studies in 2010 for that reason. And this hold was lifted thanks to the implementation of a mitigation plan, including lower doses of tanezumab, excluding patients with risk factors for RPOA, and restricting chronic concomitant use of NSAID while in the study. And I think at this stage it's important to note that RPOA is something that could be heterogeneous. We speak about RPOA type 1 when there is a significant loss of the joint space within approximately 1 year over 2 millimeters, but with no gross structural failure. So it's mainly uh, an, a problem on the cartilage. The RPOA type 2 is an abnormal bone loss or destruction with a limited or total collapse of at least one subchondral surface. And this is what is normally present in end-stage OA, and this is what is called the RPOA 2. So what has been observed in the European, the first study I showed you, is that there is RPOA in 1.4% and 2.8% of patients in tanezumab 2.5 and 5 milligram. But interestingly, the rate of total joint replacement was similarly distributed across all these three treatments, to 6.7 to 7.8%. Another side effect, which seems to be much less important, is the paresthesia and hypoesthesia. It could be a carpal tunnel syndrome, as an example, and this is reversible when you stop the treatment. And a few patients experience that. It's around between 1 to 5%. So about this RPOA, this is an integrated analysis of 3 phase 3 clinical trials. The first one is the European-Japanese pivotal study, what is called the study 1, I just presented before. The study 2 is the American pivotal study with this design you can see on the slide, with a treatment duration of 24 weeks and a study duration of 48 weeks. And the third study is a long-term study, mainly for looking at the safety over 80 weeks. And in all 3 studies, the joint safety outcomes were adjudicated by a blinding external adjudication committee with what is called the composite joint safety endpoint. You see on the right, RPOA 1, RPOA 2, but also primary osteonecrosis, also the subchondral insufficiency fracture, and also pathological fracture. A total of 451 patients were evaluated. 145 were adjudicated to have a primary outcome, which was a component of this composite joint safety outcome, with 69% being RPOA 1, 17% being RPOA 2, 12% being the insufficiency fracture, and 2% osteonecrosis. As you can see here on this slide, the proportion was higher in the tanezumab treated relative to placebo or NSAID, and the incidence increased with increasing dose of tanezumab. The RPOA1 typically occurred in the knee, but a few also in the joint. And in the joint, also RPOA1 occurred more in the KL2 or 3 at baseline. So there are some possible associations noted also with baseline disease severity. Next slide. Yes, this one. The next one, please. Yes. There is another anti-NGF in development, which is the fasinumab. Here are the recently published results of a randomized phase 2b/3 trial comparing 4 doses of fasinumab. And you see that the injection is every 4 weeks for 16 weeks, also by subcutaneous way. This is a follow-up of 36 weeks. And there was 421 patients that were randomized. And there is a greater reduction in WOMAC pain, WOMAC function from baseline to week 16 with all 4 doses level of fasinumab, but no clear dose dependence. Next slide. And just to mention that the patient had to stop analgesic medication before the randomization, 7 days before. And as expected, when there is a flare after this withdrawal of analgesic, the effect of the drug was higher, and even the effect of the placebo. This is very well known when there is it's not really a flare design, but because the patient who didn't flare were able to be included. But it's interesting to note this this flare effect. Next slide. Regarding the safety profile, I must say it seems to be quite comparable to tanezumab, meaning that it's much more a family effect rather than a tanezumab effect. It's really the full family of anti-NGF, even the pharmacological chemical compound targeting the TRAC-A, the receptor for NGF, have also this concern. So the second one is the TRP, the transcapsaicin. TRPV1 is a ion channel involved in the transmission of the pain stimuli through nociceptive neurons. The capsaicin can modulate its channel, and after a brief period of activation, the capsaicin induces a long-term desensitization of the nociceptors related to calcium influx into the nociceptive nerve terminal. This is the phase 2 double-blind randomized controlled trial looking at the efficacy on pain of intra-articular injections of the centrexion molecule, the CNTX 4975. It's a transcapsaicin injected into knee OA. And in this study, it provided a dose-dependent improvement in knee OA pain for 24 weeks. As I just said before, there is an initial period of activation of nociceptors, explaining an increase in pain sensation during the first minutes or hours. And for mitigating this procedural pain, an injection of lidocaine is usually done before injecting the compound. So next slide to conclude, just to say that there are other molecules in development with due to the fact that we know that there are many other targets, potential targets on the nerve ends and on nociceptors. And so I hope that we will be able to talk about them again in a few months with these new targets. Okay, so after this presentation, I would like now to have some thoughts from my colleagues about that.
Thank you for that insight, Dr. Berenbaum. We'd love to discuss further, but what is the update on the development of the anti-NGF program? Where does that currently stand?
So the the point is that so there has been an FDA committee meeting, advisory committee meeting for the FDA. It was 2 weeks ago, something like that. I think a couple of days ago, and the result was a negative vote, unfavorable, and the reason was that they would like to see a better mitigation plan. As I have said in 2010, when there was this halt on the molecule, they required a mitigation plan. This one, so as I've said, included the contraindication to co-prescribe NSAIDs mainly, and also to exclude patients at risk for this osteonecrosis or rapid destructive OA. But because of these numbers I have shown you, they consider that there is an efficacy, but for a benefit risk ratio, they really would like to have a better mitigation plan. And I'm sure that right now, what is in discussion is to find out what could be this mitigation plan, maybe to have a better understanding on the reasons why there is this safety problem.
Right. And what do you think are the implications for the future of the therapeutic approach involving the capsaicin-based strategy? Do you see that is going to come for approval soon? Do you think that is going to fare better?
Mm-hmm. So soon, I'm not sure, because what I just show you is a phase 2 trial. Okay, and so there is, of course, what we need now is the phase 3 study. This is important to choose the dosage and really to look at what is the effect with this chosen dosage. The second question is to be sure that we control the pain that arrive in the very first hours. There is this acute pain effect that could happen in patient. Lidocaine seems to mitigate this problem. Maybe ice pack also could be a solution. And so I think that this family of compound, because they are not alone, this family of compound could be maybe a solution in the near future. But of course, we are now very keen, and we really want to see the next study, but very exciting one.
Thank you. And we've talked a lot about these pain reduction pharmacologic therapies. As far as other potential therapies, do we foresee that there will be any success in developing disease modifying therapies, these D modes that we talked about earlier?
So there are many molecules that are in development as disease modifying. All these molecules up today, all these molecules encounter a problem, which is, even if they are able to show an effect on the structure, like an ADAMTS5 inhibitor, sprifamine, which is a growth factor, and others, with very nice results in terms of structure, with and especially on MRI. So the main problem is that in all these studies, it's very challenging to see an effect on pain, at least an effect which is clinically relevant. And so it's really a challenge today, because the FDA, in order to put the label of disease modifying drug, the FDA requires that this drug should have an effect on pain and structure, both. And so this is now today, the challenge is to find how to demonstrate that. Is it due to the molecule by itself, which is very impossible to demonstrate both because it's not the mechanism of action, or could be also that the design of the studies are not adapted to this aim. And so this is really the big discussion today, but I'm still sure that in the next 5 years, we could have one disease-modifying drug. There is one which is in phase 3 as an example, which is a Wnt inhibitor, signaling pathway inhibitor, very interesting one, by injecting it intraarticularly. And there are others also in phase 1B or in phase 2. So a very exciting area of research today.
Thank you so much for that insight. And I think there's plenty of discussion that we unfortunately don't have time for regarding like how to pick the people that are included in these trials based on OA phenotypes. How do we improve our measurement of pain outcomes with maybe different instruments? And then what are the roles for things like imaging biomarkers? But that we'll have to save for a different time. So this has been a great discussion. Thank you both. And I'd like to summarize now the things that we've covered. So OA is a common joint disorder characterized by slow progression and significant pain, disability, and impaired health-related quality of life. And despite a wide range of available treatment approaches, there still remains this unmet need for effective pain management among patients with OA. And we discussed a number of therapies that have been under investigation for the treatment of OA and OA pain, including these anti-NGF monoclonal antibodies. And while they've demonstrated efficacy in improving OA pain, there are these persistent concerns about joint safety that still need to be dealt with. So it looks like our time today is up, and thanks to our audience very much for joining us today. Please make sure you claim your CME credits by completing the post-test and evaluation form at the website that is at the bottom of the screen. All right, thank you.